Assalamu alaikum dear students. Welcome to Dr. Umi Lectures. Today we are going to discuss past university questions from corticosteroid hormones. This is chapter number 78 from Guyton Physiology. Our very first question is, what are the actions of glucocorticoids on carbohydrate and lipid metabolism? Glucocorticoids means mainly cortisol. So the effect of cortisol are to increase your blood glucose level, and cortisol does so by increasing gluconeogenesis, which means it breaks proteins in muscles, releases amino acids. Those amino acids in the liver are transaminated or deaminated, and then they are converted to glucose, which is new glucose. Moreover, it also decreases glucose uptake by peripheral tissues, especially muscles and adipose tissue, and this is done by decreasing GLUT4 carriers. So in this way, it increases your blood glucose level. This is very important to increase blood glucose because this glucose is a very important fuel for your brain, because brain only uses glucose as a source of energy. The extra glucose is also stored in liver in the form of glycogen, so glycogen storage is also increased. Moreover, cortisol also potentiates the effect of glucagon to cause glycogenolysis. So the same glycogen which is stored in your liver, when required, it can break down to provide you glucose. So cortisol upregulates the enzymes of gluconeogenesis, which are phosphoenol pyruvate carboxykinase, fructose 1,6 bisphosphatase, and glucose 6 phosphatase. At the same time, glucose indirectly inhibits the enzymes of glycolysis, which are glucokinase and also pyruvate kinase. High levels of cortisol also cause insulin resistance, and that's why this is also called as diabetogenic hormone, which means very high levels of cortisol as occurs in Cushing syndrome can cause diabetes called as adrenal diabetes or steroid diabetes. Cortisol also increases lipolysis, which means triglycerides which are stored in the fat tissue are broken down into glycerol and fatty acids. Fatty acids oxidation in muscles is increased. Fatty acids also move to liver where they are converted to ketone bodies. So in case of uncontrolled diabetes mellitus, ketosis may occur. Increased levels of free fatty acids in our blood also cause insulin resistance. This further causes hyperglycemia, and this adds to the insulin resistance. Cortisol shifts the main source of energy for muscles from glucose to fatty acids, which means during times of stress and fasting, fatty acid will be the main fuel which is used by muscles as a source of energy instead of glucose, because we are sparing glucose for our brain. In case of chronically increased level of cortisol, as in Cushing syndrome, cortisol mobilizes fats. So this redistribution of fat from periphery towards the center can cause centripetal distribution of fat in the face region. This can cause moon face. In the back of neck, this can cause buffalo hump. In the abdomen, this can cause pot belly or pendulous abdomen. Next question is, what are the actions of glucocorticoids on protein metabolism? Cortisol hormone increases the breakdown of proteins, especially in muscles, so that it can give us amino acids. Those amino acids, when they go to liver, they are converted to glucose. So this breakdown of proteins in high levels of cortisol can cause muscle weakness. And sometimes, in case of chronically elevated level of cortisol, it may become difficult for the persons to stand up from a sitting position because of weak muscles. Cortisol decreases the entry of amino acids into the peripheral tissues like muscles, and it increases the entry of amino acids into liver. So in the peripheral tissues, the protein synthesis will be decreased because less amino acids are entering into the peripheral tissues like muscles. But because amino acid entry into the liver is increased, so liver will be having more protein synthesis. Proteins which are synthesized by liver like plasma proteins, their concentration will increase in our blood. Because in liver, amino acids release their amino group during deamination and transamination reactions. So ammonia released from amino acid will be converted to urea, so there will be increase in loss of urea. So urea genesis will be increased, so there will be more nitrogen loss in urine. It will cause negative nitrogen balance. So we can say that insulin is anti-growth hormone, or it is catabolic hormone. This is why high levels of cortisol in children can suppress their growth. Next question is, list and briefly explain the non-metabolic actions of cortisol. We have just studied the actions of cortisol on protein, lipid, and carbohydrate metabolism, and all the functions other than that will be non-metabolic actions. For example, cortisol is important to maintain vascular responsiveness to catecholamines. Catecholamines, which are epinephrine, norepinephrine, they act on blood vessels and heart. So their receptors, alpha and beta receptors, their number will increase in case of presence of cortisol. So cortisol have a permissive role. which means the vasoconstrictive action of epinephrine or epinephrine on the vessel's alpha 1 receptors will be increased in the presence of cortisol. And similarly, cortisol's permissiveness also potentiates the action of glucagon, which means glucagon cannot perform glycogenolysis in liver in the absence of cortisol. So cortisol's presence increases the action of some other hormones. This is called as permissive role of cortisol. This is especially important for catecholamines and glucagon hormone to potentiate their effect. Cortisol also has anti-inflammatory action, and this is by decreasing the release of arachidonic acid from the phospholipids of cell membrane. This decreases the synthesis of prostaglandins and leukotrienes, which are very important mediators of inflammation. It also decreases the synthesis of interleukin 2, which is important for the proliferation of T lymphocytes. So in this way, it suppresses our immunity as well. Cortisol decreases the release of histamine and serotonin from mast cells and platelets. In this way, several mediators of inflammation are decreased and cortisol causes anti-inflammatory action. Because cortisol decreases the production of interleukin 2, which is very important for proliferation of T lymphocytes, by suppressing their proliferation, it decreases our immunity. So this is why cortisol hormone in pharmacological doses can be administered for treatment of some diseases like to treat some allergic reactions and also to treat autoimmune diseases like myasthenia gravis. It can also be used to prevent the rejection of transplanted organs like kidneys. However, when we give increased level of glucocorticoid hormones to suppress our immunity, this has a risk, and that risk is of increased infections. Cortisol also plays a very important role in stress adaptation. So we can better cope with stress if cortisol hormone is there in our body. This is because cortisol mobilizes fuels at the time of stress. It causes protein breakdown, so it provides us amino acids. It also increases blood glucose level by gluconeogenesis. It also causes lipolysis, so increases free fatty acids in our blood. So these amino acids and fatty acids can be used for repair of tissues if during the time of stress there is some damage to the tissues. These fuels and nutrients can be used for the tissue repair. During time of stress, cortisol also maintains the functioning of our cardiovascular system, especially the vessels they constrict because cortisol increases the responsiveness of vessels to alpha 1 receptors because it provides permissiveness to the catecholamines. Cortisol also inhibits the bone formation. It decreases the collagen type 1 synthesis, which is one of the main component of the bone matrix, and it also decreases the absorption of calcium from intestines. This is why chronically elevated level of cortisol in our blood can increase the risk of fractures by causing weakening of bones. Cortisol also increases gastric acid secretion and decreases the proliferation of gastric mucosal cells. And in case of hypercortisolism, peptic ulcer can occur. Next question is how cortisol secretion is regulated. There is an axis between hypothalamus, anterior pituitary, and adrenal cortex. This regulates cortisol level by negative feedback. Hypothalamus releases a hormone called as corticotropin releasing hormone or corticotropin releasing factor. This is released from the paraventricular nucleus of hypothalamus. It is released in the median eminence of hypothalamus, and from there through the hypothalamo-hypophyseal portal circulation, this enters into the anterior pituitary, where it acts on the corticotroph cells through cyclic EMP pathway, and the corticotroph cells release ACTH hormone from the anterior pituitary. ACTH hormone acts on the adrenal cortex through cyclic EMP pathway, and zona fasciculata and zona reticularis they release cortisol hormone. This cortisol hormone, when it is high, it acts through negative feedback on the anterior pituitary and on hypothalamus. So there is double negative feedback, and this negative feedback of cortisol or anterior pituitary and hypothalamus can be overridden by two factors. One of them is stress. Whenever there is increased level of stress, whether physical or psychological stress, for example, pain, trauma, infections, so any kind of anger, anxiety, emotions. So stress increase acts on limbic system, especially amygdala, hippocampus, and then through hypothalamus there is increase in release of cortisol hormone. The other factor which can override this negative feedback mechanism is circadian rhythm or diurnal variation. Suprachiasmatic nucleus of hypothalamus, which is the major biological clock of the body, this acts on the paraventricular nucleus. So early in the morning, when we are just going to rise, for example, at 7 8 a.m., there is highest level of cortisol in our blood, and lowest level of cortisol is seen late in evening or early night time, for example at 10 or 11 p.m. when we are just going to sleep. Next question is a scenario. A 45-year-old woman presents with hirsutism, striae, bruising, acne, and hyperpigmentation of the skin. After a thorough physical examination, the physician notes that she also has hypertension and shows signs of buffalo hump on her back between the shoulders. The laboratory test shows elevated cortisol level in the blood, so she is given a dexamethasone suppression test. Her results are positive, that is, elevated ACTH is not suppressed. What is the likely diagnosis? All these features suggest that this is Cushing syndrome. So diagnosis is Cushing syndrome. Explain the reason of characteristic accumulation of adipose tissue in the facial, truncal, and cervical region of the body in such cases. So the answer is that cortisol hormone, when chronically elevated, as in Cushing syndrome, it shifts our metabolism from carbohydrate to lipids. So there is more fat breakdown, lipolysis, and those lipids they are redistributed mainly from periphery towards the center, and fats they accumulate in the center region of body, in the abdomen, in the chest, in the fish, and in neck region. These persons with Cushing syndrome also have increased food intake, so this also contributes to the accumulation of fat in the central region of the body. Cause of hirsutism is increase in androgen level, because cortisol and androgen both are released from the zona fasciculata and zona reticularis, and both of these zones are under control of ACTH hormone. So when there is increase in cortisol production, most likely there is also increase in androgen production, and these androgen they cause hair growth in the male like distribution in females. This is called as hirsutism. Causes of hypercortisolism, tumor of anterior pituitary, which increases ACTH production, and that has increased stimulation on the adrenal cortex to increase production of cortisol hormone. It may be because of tumor of the adrenal cortex, especially in the zona fasciculata and zona reticularis, that increase the production of cortisol hormone. It may also be because of some hyperplasia of the adrenal cortex, which increase the production of cortisol. Or it may also be because of exogenous administration of high levels of cortisol. For example, a person having rheumatoid arthritis, if is being treated with high levels of dexamethasone or prednisone hormone, that increases cortisol level chronically and can cause hypercortisolism or Cushing syndrome. Next question is, what is the difference between Cushing syndrome and Cushing disease? Cushing disease is when there is increase in production of ACTH primarily from the pituitary gland. It means there is a tumor of pituitary gland which primarily causing the increase of ACTH production. That increase in ACTH is acting on the adrenal cortex to increase stimulation and producing hypercortisolism. However, if the issue is in the adrenal cortex, and that is causing increased production of cortisol from there, which means primary adrenal hyperplasia, that is called as Cushing syndrome. In both of these cases, Cushing disease and Cushing syndrome, there is increase in production of cortisol. However, in Cushing disease there is increase in ACTH level, but in case of Cushing syndrome, because of negative feedback effect on the anterior pituitary, there is decrease in production of ACTH hormone. As in Cushing's disease, there is a tumor of pituitary. That tumor of pituitary, if compresses on the optic chiasma, can cause bitemporal hemianopia. So the visual field defect may be there. But in case of Cushing syndrome, usually this kind of visual field defect is not there. The treatment for Cushing syndrome is to give some drugs which decrease the production of cortisol from the adrenal cortex, like ketoconazole. But the treatment for Cushing disease is surgical removal of the ACTH producing tumor. Another question is, enumerate 6 features of Cushing syndrome. So you just have to list some important features of Cushing syndrome. So one very important feature of Cushing syndrome, it causes hyperglycemia and it can lead to diabetes mellitus. There is muscle wasting, especially the proximal muscles in shoulder and hip region, they are wasted. And central obesity, fat is deposited in the center, so pot belly and moon face, buffalo hump. It can also cause bone weakening and osteoporosis, so the increased risk of fractures. Abdominal striae, so stretch marks may be seen on the abdomen because there is more protein breakdown. So collagen, which is a protein in the connective tissue, if it is also broken down, so it can lead to stretch marks by stretching of the abdominal skin. In females, it can cause virilization like hirsutism and also deepening of voice. It can also cause menstrual disorders, and it can also cause hypertension by increasing the retention of water. Cortisol also increases triglyceride and cholesterol level in our blood, so it increases the risk of atherosclerosis and cardiovascular diseases. And because it has anti-inflammatory action, by suppressing inflammation, it decreases wound healing. Next question is, a 45-year-old woman has been taking glucocorticoids for last 1 year for rheumatoid arthritis. Now she has developed moon phase, buffalo torso, central obesity, hypertension, and hyperglycemia. Name the condition she is suffering from. This condition is Cushing syndrome. Give the physiological basis of developing hyperglycemia and hypertension in this condition. Hyperglycemia is because of increase in gluconeogenesis and also decrease uptake of glucose by the peripheral tissues like muscles and adipose tissue. It decreases the utilization of glucose, which means it decreases glycolysis or oxidation by the peripheral tissues. Cortisol hormone also has anti-insulin effect, so that's why it increases our blood glucose level. The physiological basis of hypertension is that cortisol has some mineralocorticoid activity. So just like aldosterone, it also increases the retention of sodium and water. More is the fluid in our blood, more will be venous return, more will be cardiac output, and that will increase your blood pressure. And also cortisol has permissive role, which means it potentiates the action of catecholamines by increasing their alpha and beta receptors on cardiovascular system. For example, alpha 1 receptors, they cause vasoconstriction. By increasing the total peripheral resistance, it increases blood pressure. Next question is, a 36-year-old woman present to gynecologist with complaints of amenorrhea and hirsutism. She also noticed an increase in her weight and easy fatigability. On examination, she has very rounded face and central obesity. Her blood pressure is elevated and as is her weight compared with previous visits. On abdominal examination, she is noted to have stria and male-like distribution of hair. Laboratory investigation revealed increased cortisol production and failure to suppress cortisol secretion normally when dexamethasone is administered. What is most likely diagnosis? The answer is Cushing syndrome. This is important to note that when you give high dose of dexamethasone, if it suppresses ACTH secretion from the anterior pituitary and cortisol secretion from the adrenal cortex, then this is Cushing disease. But in case of Cushing syndrome, for example, if there is primary adrenal hyperplasia, in this case, even high dose of dexamethasone will not be able to suppress the cortisol secretion. Next part is list the effects of cortisol on carbohydrate and protein metabolism. We have already discussed. Next is what is the mechanism of anti-inflammatory effects of corticosteroids. We have already discussed. Next question is give the physiological actions of aldosterone hormone. Aldosterone hormone is a mineralocorticoid. It is produced from the zona glomerulosa. What are its actions? Because it regulates our minerals, mainly sodium and potassium, that's why we call it mineralocorticoid. It increases the reabsorption of filtered sodium from the distal convoluted tubule of kidney and from the collecting duct. This acts on the principal cells of DCT and increases the reabsorption of sodium by inserting more sodium channels there. It also increases the secretion of potassium from the principal cells of the DCT, and it also increases the secretion of hydrogen from the intercalated cells of the distal convoluted tubule. So in a nutshell, we can say that aldosterone increases reabsorption of sodium and it causes loss of potassium and hydrogen ion in urine. Next question is, a 30-year-old female visited medical emergency with complaints of uncontrolled blood pressure and muscle weakness. On history, she revealed that she has developed hypertension for last 1 month and has been taking antihypertensive medication regularly, but blood pressure is not controlled. Laboratory examination revealed hypernatremia, hypokalemia, and metabolic alkalosis. What is the most likely diagnosis? The answer is Conn's syndrome, CONN. Conn syndrome. Describe the pathophysiology of development of hypokalemia, hypernatremia, and metabolic acidosis in this patient. Hypokalemia means decrease in potassium in our blood. This is because the main function of aldosterone is to increase reabsorption of sodium and cause secretion of potassium ion and also secretion of hydrogen ions. So when there is more secretion of potassium, it means potassium will be lost in urine. So that's why potassium level in our blood will decrease. So hypokalemia. Because it increases the reabsorption of sodium, so that's why it has tendency to increase your sodium level in the blood. So it can cause hypernatremia. And because it can increase the loss of hydrogen ions by increasing the secretion from distal convoluted tubules of the kidney, so that's why this can cause more loss of hydrogen ions, which are acids. Hence it can cause metabolic alkalosis. Next question is, what are the factors that regulate secretion of impaired hormone? Because in this case there is increase in aldosterone secretion. Aldosterone is produced from the zona glomerulosa, the outermost zone of the adrenal cortex. Two important factors regulate the secretion of aldosterone, and these factors are not coming from anterior pituitary. These are angiotensin 2 and potassium ion. And you know very well that angiotensin is controlled by the renin angiotensin aldosterone mechanism. And some important stimuli to increase the production of angiotensin 2 in our blood are your low blood pressure, low extracellular fluid volume, sympathetic stimulation, and low sodium in your blood. So all these factors, they increase the production of angiotensin 2, which stimulates our adrenal cortex, zona glomerulosa, to increase the production of aldosterone. The other factor is potassium ions. So when there is increase in potassium ions, it causes the production of aldosterone, and then aldosterone has the function to cause loss of potassium in urine. Next question is, what is the cause and clinical features of Conn syndrome? We have already discussed the clinical features. So just to summarize, the cause of Conn syndrome is aldosterone secreting tumor of the zona glomerulosa. It increases your blood pressure by causing the retention of sodium and water. It increases loss of potassium, so hypokalemia. It increases loss of hydrogen, so metabolic alkalosis. There is decrease in renin by the negative feedback mechanism. Next question is, what is aldosterone escape phenomena, or the escape phenomena in primary hyperaldosteronism? As you know that aldosterone causes increased retention of sodium and water, and this has tendency to increase your blood pressure. So hypernatremia or increased sodium, which may be caused by aldosterone, can be overcome by increasing your blood pressure. So because when our blood pressure will increase, this has a natriuretic effect. So increase in blood pressure will act on kidney, this will increase your GFR, and there will be more loss of water and sodium in urine. So it means in case of increase in aldosterone level, when your blood pressure will rise, it will overcome the salt retaining effects of excess aldosterone, because increased blood pressure will cause more loss of water and sodium in urine, and hence your sodium level in the blood may come back to normal at the expense of increased blood pressure. This is called as aldosterone escape phenomena. So what is escaping? Your kidney is escaping from the salt retaining effects of aldosterone at the expense of increase in blood pressure. Moreover, in this case, because there is increase in extracellular fluid volume, there is also production of atrial natriuretic peptide, which also has a natriuretic effect, so the extra sodium will be lost in urine. So kidney will escape from its salt retaining effects of aldosterone. Next question is, a 40-year-old woman is diagnosed to have adrenal insufficiency. Name the disease and describe the disturbances produced in the body due to adrenal insufficiency. The primary adrenocortical insufficiency is also called as Addison's disease. In this case, there is decrease in production of both cortisol as well as aldosterone. So mineralocorticoids and glucocorticoids both are deficient. So the features in the patient will be of both glucocorticoid deficiency and mineralocorticoid deficiency. Because of deficiency of aldosterone, there will be decrease in blood pressure. There will also be hyperkalemia, because there will be less loss of potassium, so potassium level in the blood will increase. And also because there will be less loss of hydrogen in urine, so there will be metabolic acidosis because of retention of hydrogen ions in the blood. And due to glucocorticoid deficiency, there will be hypoglycemia, because normally cortisol increases your blood glucose level, and in case of decreased cortisol level, glucose level will decrease. There will also be weight loss. High cortisol increases weight and low cortisol decreases weight. There will be muscle weakness because of increase in potassium level in our blood. There will be effect on the resting membrane potential, so affecting the excitability of nerve and muscle. There will be muscle weakness. There will be decrease in pubic and axillary hair in women because of decrease in androgens. And hyperpigmentation will also occur on the skin and mucous membranes. This is because of increase in ACTH level, because cortisol is low and negative feedback increases ACTH level from anterior pituitary. And because ACTH has melanocyte stimulating effect, and also there is increase in production of melanocyte stimulating hormone, hence there is more pigmentation. And in this patient, the ACTH level will be increased. So treatment of a patient having Addison disease is to replace glucocorticoids and mineralocorticoids. Otherwise, this patient will die, because both of these hormones are essential for our life. Next question is, a 45-year-old male was reported to have tuberculous destruction of adrenal gland. So the adrenal cortex has been destroyed. On examination, he has hypotension, low blood pressure, extreme muscle weakness, and melanin pigmentation, especially prominent in the lips and nipples. His laboratory investigations show hyponatremia, low sodium, hyperkalemia, increased potassium, and metabolic acidosis, acid retention. What is most likely diagnosis? This is because of Addison's disease. Explain the pathophysiology of all the clinical features and lab tests mentioned in this scenario. So I will discuss pathophysiology of each feature one by one. First, hypotension. Because cortisol and aldosterone, both of them increase fluid volume, they cause high blood pressure. When both of them are low, there will be less blood pressure because there will be less retention of fluid in the body, and vasoconstrictive effect will be decreased in the deficiency of cortisol hormone. Extreme muscle weakness is because of hyperkalemia, which is caused by low aldosterone level, because there will be retention of potassium, and potassium affects our resting membrane potential, so muscle weakness will occur. Pigmentation is because of negative feedback effect, because cortisol is low, so due to negative feedback, ACTH production will increase. And because ACTH is produced from POMC, pro-opiomelanocortin. When there is increase in production of POMC, there will be increase in production of ACTH and melanocyte stimulating hormone. Both melanocyte stimulating hormone and ACTH hormone, they have increased stimulation of melanocytes. They have increased stimulation of melanocytes and hence more pigment production in the skin and mucous membranes. Hyponatremia is because of less sodium retention, because there is less aldosterone, and hyperkalemia is because of less secretion of potassium due to less aldosterone. So potassium will be retained in the body. And metabolic acidosis is because of less secretion or less loss of hydrogen ion in case of deficiency of aldosterone. So retention of hydrogen ion will cause metabolic acidosis. Our last question today is, what is Addisonian crisis? When does it occur? Those persons who are having Addison's disease, if they are not having some stress, they can withstand the deficiency of glucocorticoids. However, when there is already glucocorticoid deficiency in the body and if they face some stress, for example, they get some trauma, some fracture, surgical operation, or they are fasting, in such a stress, there may be sudden collapse of the person. Blood pressure may drop and the person may become unconscious and the person may die. It can be a fatal condition unless the person is given very high doses of glucocorticoids. In such a case, when the person is already deficient in glucocorticoids and stress further increases the requirement, 10 times or even more glucocorticoids may be required to save the life of the person. So this is a medical emergency, Addisonian crisis, and if not treated, this can cause death of the person. So in this session, we have discussed past university questions from chapter 78 of Guyton Physiology, which is on corticosteroid hormones. In another session, previously I have discussed past university questions from chapter number 79, Guyton Physiology, and that is from insulin glucagon and diabetes mellitus. In my next session, I will discuss university questions from ANS Physiology and Physiology of VN. I hope these discussions will be very useful for your exam preparations. All the best. Please like, share, and subscribe. Thank you so much for watching. See you next time with another video.